topic for today was the influence of corneal incision site on astigmatism after cataract surgery. It was a single center experience. We evaluated patients which we did at our center. So purpose of this study was to evaluate the effect of variation in site of clear corneal incision on surgically induced astigmatism. 3 incision sites were evaluated: temporal, superotemporal and superior. So what is SIA? Surgically induced astigmatism, it is a vector. It has both magnitude and angular direction, and both this should be kept in mind while calculating the mean SIA. So there is like a torque and flattening or steepening can occur perpendicularly. So angular will be the SIA, and depending on both of this factor will be the surgically induced astigmatism after the surgical procedure. So the astigmatism, this is the astigmatism excluding any astigmatism, corneal astigmatism which the patient already has. So this induced astigmatism is a reflection of cataract incision, then its closure and subsequent wound healing. So if there is excessive tight wound because of suturing, it induces corneal steepening in that axis. If there is any wound dehiscence or wound gap, that leads to flattening of cornea along that axis. So basically compression steepens the axis and any gapping induces a flatter cornea. Now surgical induced astigmatism depends upon various factors like the axis on which it is acting, the axis on which we take the incision, then the location, the size, so 2.2, 2.8 or 3.2 mm or higher. Gradually as the size of the incision increases, the surgically induced astigmatism also increases. The shape, there are various shapes: linear, square, rectangular. The form, how the wound is formed, like biplanar, uniplanar, biplanar, triplanar, architecture of the wound, and any pre-existing corneal astigmatism if present. So we evaluated total 90 patients in our group, in our study, and then they were divided randomly according to the location of clear corneal incision. Complete ocular examination was done, including the keratometric readings, and patients were followed up on day 30 and day 90. So inclusion criteria for my study was all the patients who were undergoing cataract surgery who consented for the study, excluding the patients who had any previous any coexisting pathology, any anterior or posterior segment surgery. Also patients with corneal astigmatism over 1.5 diopters were excluded. Then patients who required any intra-op suturing were excluded because that would change our dynamics. Now for statistical analysis, it was calculated as the postoperative astigmatism minus the pre-op astigmatism, and we didn't take the axis into consideration. So we just evaluated the amount of surgically induced astigmatism that was present, the astigmatism which was present after our stipulated 90 days period. So it was evaluated using paired t-test using SPSS 18.0 software, and it was evaluated using 5% level of significance. So and also the patients were divided into temporal, superotemporal and superior groups. Patients also were divided in that groups having with the rule astigmatism, against the rule astigmatism, and patients who showed some keratometric readings but did not accept any any cylindrical power. So this was to evaluate if the patients with the rule, against the rule, who had better the correction index was higher in same in both, or it was different for both the astigmatism. So results of surgically induced astigmatism on day 30 were compared to day 90. So for temporal it was 0.83 reduced to 0.76. For superotemporal it was 0.92 which was reduced to around 0.89, and superior was 1.19 reduced to 1.01. So for at the end of the study, we concluded that temporal group surgically induced astigmatism was lesser in the temporal group as compared to the superior and superiotemporal group, it gives better visual outcome, good optical quality and better patient satisfaction. Also the correction index was higher for against the rule patient as compared to with the rule, because we especially in temporal incision, because the incision was given at its steeper axis. So to compare the two incisions, comparing the temporal and the superior incision. Now temporal incision, the distance between the corneal apex, that is our visual axis, and entry point is higher. So it any change at that axis, the comparative change there forms a lesser, creates lesser impact as compared to the if incision is taken at a superior site where it is nearer to the limbus, and also near superior limbus where it is nearer to the central visual axis. The temporal incision, if we have to choose between two and we evaluate it according to the patient, so it is recommended for patients with against the rule astigmatism, where for superior incision we take patients, it is better for with the rule astigmatism with steeper axis at 90 degree. Also the ease of operation and more accessible is our temporal incision. The limitations of our study were that it did not reflect the true corneal astigmatism, as the AR machine takes into consideration the total astigmatic power of the eye. Also it does not consider the posterior corneal surface. Thank you.
Thank you so much, Dr. Monica Shah, for a wonderful presentation, and you made basic of phaco dynamics very easy, and your corneal incision was